Thank you, Torcine. So this is how we can translate what Andrew said as an anatomist in the lab after with clinical consideration. So this is my disclosure slide. So as mentioned by Andrew, the anatomy is very, very variable. And it's phenomenal. This region of the left atrium, it's the smallest, but actually the most variable part of the left atrium. I suspect potentially of the heart. And there's tons of different shapes, different size, length, and it can become challenging when we consider to close this region with a device. So, as mentioned by Andrew, there's specific region that we know. He mentioned the ostium here. He mentioned the neck. He mentioned the lobar region behind, so the most variable part of the appendage. But we should probably translate that also in the lab when we talk to each other with the echographer, with your partners. And we can potentially find other terms for what Andrew mentioned. So if we have here the ostium, we can also say that it's the mouth of the left appendage or the orifice of the appendage. So the transition between the left atrium and the appendage itself. The neck can be called also the landing zone because it's typically the region where we are going to deploy the device, any kind of device. So the landing zone or even the ostium, if you're on the watchman operator, often this region, you will call this region the ostium because it was named like that since the beginning. So that region is typically 1 to 2 centimeter inside the ostium. So you can understand that it can be confusing at the end if we don't mention all that, because if you say ostium, you can potentially have in mind this part, which is the orifice of the mouth, or this part if you're, let's say, a watchman implanter. So you just need to know what is out there concerning this various part of the appendage. So if I start with the ostium, as mentioned again by Andrew, it's typically oval, can be round, but most of the patients, they have an oval ostium. And it can be challenging to fit a round device in an oval region, especially if it's very, very eccentric. So for that reason, and knowing the device that we are using the most, the Watchman and the Amulet now, the plug before, it can make sense to have another mechanism to seal well the ostium, because if you force a round device in an oval structure, you suspect that you will end up with more residual leak, and it's the case with, for example, a watchman who will not seal after the orifice of the appendage. Concerning the lobe morphology, this is something that we show all the time, including Andrew. This is the most common form of a lobe, so different kinds, chicken wing, cactus, windsock, and cauliflower. The most common one is by far the chicken wing. I think it's relevant to present that, not only because we really absolutely want to define that during each procedure, but it makes sense to define that because some anatomy are a lot more challenging than others if we consider closure. And this is something that we covered also during the proctor meeting yesterday, because even if you have tons of experts in a room, we don't necessarily agree on how we close different anatomies, but we typically agree on the fact that some anatomies are clearly more challenging to close than others. So I'm just mentioning few anatomies that they are more challenging to close. A chicken wing appendage, especially with an early curve, so the curve right after the ostium. The cauliflower appendage, so not very common, but when it happens, it's often challenging to close because typically the ostium or the orifice is quite large. Often the depth is not, it's quite minimal. Appendage with proximal lobe, often or sometimes challenging. Very small or very large appendage. or very short appendage. Concerning chicken wing appendage, as mentioned by Andrew again, it's when you will find a curve, a 90-degree typically bends in the course of your lobe. It can be very proximal, it can be more distal. If it's distal, it's not a big thing. But when it's curving like this very proximally, it can be challenging to have enough working depth to deploy a device. Certainly if you consider a watchman, because typically a watchman, you need a good working length. So this is something that we can potentially, not potentially, but that we are closing often quite easily with the amulet, using different technique. There's a technique that we can use called the neck technique, where you typically deploy the device in the proximal portion of this appendage, like the regular fashion. But there's another technique, like the sandwich technique, where you can potentially consider to deploy your device more distally after the curve, the lobe, and then retract the appendage and deploy the disc over the ostium. This is something that we that I demonstrate here on the angio. But this is something that you can appreciate is also here on echo. So we have your chicken wing appendage, and you will, in this case, using the sandwich technique, deploy the lobe in the distal part of the appendage and then deploy your disc over the orifice. So this is typically an anatomy that we can treat more easily, if you will, with an amulet, for example, than a watchman, because typically, as I said, with the watchman, the problem it's the usable length for deployment of the device should be at least equal or greater than the size of the landing zone. So often, if you don't have enough length, it will just not be possible if you cannot bias your device to deploy a device in this morphology of appendage. Another very challenging anatomy sometimes is the cauliflower appendage with often a large ostium, minimal depth. This is another appendage that is potentially difficult to close, for example, with the watchman. This is the LAAO caudal view, showing more the proximal region. You cannot appreciate very well the distal part, but this is something that it's better seen on the LAAO caudal view. And you can appreciate that it's a cauliflower appendage, not very deep, but quite broad base. So again, this is something that you can close quite easily with an amulet, because you don't require a lot of working depth, but a lot more challenging with the other device. Now I'm showing an appendage with a proximal lobe. As mentioned by Andrew, most of the appendage, they have more than one lobe, typically an average 2 lobe. This is an appendage with 2 lobe, but one of the lobe, and this is something again that you can appreciate even better on the LAAO caudal view. This appendage has a very proximal lobe. I think it was quite interesting to know from Andrew that you can have also external lobes, so even outside the appendage. But this is a very proximal lobe, and this is another very challenging anatomy to treat with a watchman, because you typically cannot cover well the proximal lobe, and having a disc that will cover the orifice, it represented a clear advantage of a device like the amulet. And this is the device in place here, deploying the proximal portion, but covering all the orifice of this appendage with the disc approximately. So size of the appendage is something also that it can be challenging, especially when it's very small or very large. I'm putting the charts of the most common used device side by side. So for the watchman, the size of appendage that you can treat at this point, it's from 17 to 31 millimeter. And with the amulet, it's from 11 to 31 millimeters. So giving more, again, range of more option to treat like very small or even larger appendage. Depth, it's also an important feature to consider for occlusion. As I mentioned before, the usable left atrial appendage length for the Watchman should be at least equal to the size of the device. So if you're using, for example, a 33 millimeter device, you need at least 33 millimeter depth to put your device in place. So this is again a bit of a limitation of this device. For the amulet, the depth that you require is only 1 centimeter. So giving the opportunity to treat like a shorter appendage. So I will conclude my talk by saying that left atrial appendage anatomy is extremely variable. I think you know that. We are repeating this. Most of the appendage, I think, in clinical practice can be close with the current device. So leaving sometimes difficult anatomy to treat, but most of the difficult anatomy can be managed also with the amulet because of the unique feature of this device. Thank you very much for your attention.